Hello and welcome. This is like a not scripted basic overview because this allows us to slow down a little bit and spend this week just digesting some of the umbrella foundational topics for peds. And then over the next few weeks, as we start digging in more into sort of developmental pediatrics, it will start to fill in the skeleton that we have created in this first week. I'm going to go over some basic information on hospitalization, illness, and play, which corresponds with what is in Chapter 10 of your ATI book. And then also Chapter 1, which talks about family configurations and gives you a bit of an introduction into PEDS. One thing I do want to mention about PEDS development is it tends to be the most shocking part for students because it goes against everything that you have learned how to study for in nursing school, right? You're used to going through systems and doing dysfunctions, and now we are coming to a screeching halt and having to really go back to rote memorization. And it can be a rough adjustment for students to have to change the way that you study for a little bit before we roll back into things that feel more familiar, which will be more like med-surg for kids, right? There's not a whole lot that I can say is like a blanket strategy for everybody because I don't know you. Use what you know, use what works best to memorize. I really highly recommend, and will repeat this probably over and over this semester, that you write things down by hand instead of typing, or use a stylus on your iPad. But that brain to pen connection is really important. And when you're trying to memorize things like developmental milestones, gross motor, fine motor skills, that repetition and that rote memorization is going to be really important. Okay? So, diving right in to kids and the hospital. Hospitalization is a huge stressor, right? Even for adults. If you have ever been in the hospital, if you have a family member who has been in the hospital, it's a very stressful and anxiety-provoking circumstance, and that is true for kids as well. The more complicated part with kids is that they also don't have the understanding all the time of what is going on to cope with that disruption. And so when kids are in the hospital, they may have delays in their developmental milestones or regressions to previous stages. It can negatively impact their mental health, especially long-term or chronic or frequent hospitalizations. And then they will have manifestations of stress, just like you and I would. Their change in daily life and separation from familiar people and settings can really affect them. Think about the stereotypical 2-year-old that's screaming and crying when they're getting dropped off to daycare because it's not what they're used to. Now, in this case, hopefully, caregivers are staying at the bedside, but there's still that element of the routine being disrupted and of not having their safe spaces. And so it can really be a difficult transition for kids. This will obviously manifest differently depending on their age. Okay, so this table here shows you some example behaviors in early childhood, late childhood, and adolescence of how we might see that stress. Obviously, infants can't articulate their feelings and they don't understand why they are there, so they might be distressed or confused. They are in the stage of trust versus mistrust, which will become more familiar to you in the next few weeks, but they're used to having their needs met at certain times and having their behaviors match up with reactions from the people around them, and that can change in the hospital. Toddlers will recognize the disruption to their routine, but the lack of full understanding of it, and so then they can be uncomfortable or anxious. Preschoolers have vivid imaginations, so they will oftentimes fear medical procedures or think that hospitalization is a form of punishment. School-age children obviously can grasp those reasons better, but they are still going to be stressed out because they are missing school and they're not at home. They might resist, they might not be cooperative. And then adolescents, obviously we're getting closer to adults here, but they are still going to experience stress if any interventions might affect their body image or affect their perceived peer acceptance. So just be aware that each age group has its own special reactions to things. And you're not going to see this a lot. I will say, truthfully, in the hospital, most of these kids seem very well adjusted. Okay, this is not going to be a unit of crying children where everybody's really upset. PEDS is actually quite upbeat and optimistic. Kids are very resilient, but it's important to understand that it's still a stressful situation. And even though they are playing and we are playing with them and we are trying to make things more comfortable, there is still this underlying stressful situation for them and their parents. Okay. So, as I had mentioned, there's different considerations for development, and PEDS development is arguably the most probably complained about. I don't want to say hated because I don't want to use that word, but the most disliked part of pediatrics or of this course for students, but it's also the most important. And I want you to take a moment to think about why understanding pediatric development is significant to caring for children, what it can impact. The first thing, because I'm going to give you the answers, because obviously I'm talking to myself here. The very first thing is we want to know if children are developing appropriately. If we're thinking about primary care and we're thinking about going into a doctor's office, a lot of that assessment is this child on track developmentally? Are they meeting their milestones? Because there could be causes that we want to look into. If there's any sort of delays, we want to intervene early so that child can catch up. We want to catch any illness or underlying disease process that might be causing delays. We also want to follow this up with looking at their nutrition, because nutrition is incredibly important, not only for physical growth, but also for developmental growth and brain growth. And so children that are not getting fed appropriately, whether due to socioeconomic reasons, maybe they live in a food desert, their families can't afford it, maybe due to lack of education for the family, maybe due to underlying issues where that child isn't interested in eating, or even due to cases of child abuse and neglect. That lack of nutrition can severely impact their development and their growth. And so that is one of the primary things that we're looking at as pediatric care providers. The other thing is how we are going to, and this is more practical for you guys, how do you relate to these kids? How do you talk to them? How do you establish rapport in the hospital? If you go up to a toddler and you talk to them like a 16-year-old, you're not going to probably get that same connection that you would get if you understood what sorts of interactions are beneficial to them. With that said, this is a huge source of anxiety for students, because students will take this to the other extreme and think, I have no idea how to talk to a child, and the minute I do, I'm going to mess something up. And I want you to be reassured that's not the case. There is a huge margin of error here, okay? I probably wasn't all that great at understanding development and how each age group fit into those categories until I had my own kids. I had been working for 5 years at that point, and it was like it would click. I was like, oh my gosh, I understand babies now because I experienced babies in my everyday life. So those of you who have babysitting experience will probably find this easier, okay? Those of you who have maybe cared for younger siblings or cousins, you're going to find certain age groups to be more comfortable, and that's great. I love that. And I also want you, though, to challenge yourself to take care of an age group that maybe you're not familiar with. And with that said, you don't have a choice. I'm assigning you, and Allie, the other clinical instructor, will be assigning you age groups, but try to go in with the same kind of confidence regardless, and look at this as it is, which is practice and a puzzle. It is a puzzle to figure out. Even if we have your kid as a toddler, there's such a wide range of behaviors that unless you know that child individually, you're not going to be able to go in there and flawlessly interact with them. Everybody knows that. Even parents sometimes aren't great at it. So don't hold yourself to a standard that you're not going to be able to achieve, and don't let this paralyze you. Just be aware that it is a tool that you can utilize. And if you mess it up and you go in there and you ask a 4-year-old, can I take your blood pressure now? And he goes, no. Fine. Then you know what? We'll figure it out. And you'll learn from that. And maybe next time you'll say, hey, do you want to take your blood pressure first, or do you want to do your temperature first? And that's how you learn to give appropriate choices, right? By going in there and making those mistakes and learning from it and moving on. So don't let this whole concept of pediatric development feel like a barrier for you. Rather, think of it as an extra tool that you have in your toolbox to make getting cooperation from these kids, or getting to know them, or getting them to do what they need to do easier, okay? And then the third, and arguably probably most important reason for understanding development is screening for when kids come through the ED, for example, okay? And let's say you have a child that comes into the emergency room with a depressed skull fracture, and the caregiver says, oh, he stood up on the changing table when I turned around to grab a diaper, and he tripped and he fell. But this child's 3 months old, right? Now, most of you, hopefully, probably know a 3-month-old doesn't walk, right? But what if this child was 7 months old or 8 months old? At what point would you feel confident that you knew that child in no way was mobile enough to get off of that table by themselves and fall? So that you could then figure out that there was maybe a contradiction here with the story and the injury, and know that this is likely an abuse situation rather than a realistic expectation of a developmental, I don't know the word I was going to say, but something that developmentally is expected in that child, right? Like a 13-month-old who went running across the floor and fell and hit his head. That would be more reasonable because he's learning to walk, but a 3-month-old, absolutely not, okay? And also for things like neurochecks or medication effects. We want to know, what am I expecting this child to do? What do I expect this child to be capable of doing? And if they aren't, why not? Those are the questions you need to start asking yourself. A lot of the questions about development on the NCLEX and on your exams are going to be being able to recognize when something is not normal. And I don't want you guys, as we go through this, and I am leading into this as a really long chat because this is a huge anxiety-inducing area of this course for students, don't stress out about getting really granular about when things happen. Most of the questions are going to give you a pretty wide range where if you know it, you're going to know it. Okay. Honestly, even I don't have every single thing memorized down to the week, right? You can. I have other things that come into my brain and that kind of shoves off to the side. But if I read an NCLEX question, I can usually answer it because they're not saying, hey, you have a 4-month, 1-week-old child who still has head lag. They're going to say, you have a 7-month-old child who is still showing head lag, where you can be like, okay, head lag is supposed to disappear by 4 months. If they're 7 months, that is probably an abnormal finding. It's not going to ask you to split hairs. And so I don't want you to spend unnecessary time splitting hairs, okay? Make a chart. Use whatever online resources you find useful, okay, that work for you. Again, I don't know you guys yet. I don't know what you enjoy doing or what is effective for your study habits. I obviously have opinions, but you right now know what you like best. There's a website called PicMonic that does some really great medical illustrations and mnemonics, and they have a pretty robust PED section. If you have access to PicMonic, or if you want to grab a trial for the next couple of weeks as you study this, I think that's a great resource if you're more of like a visual mnemonic learner. I know a lot of you like Quizlet. You can make your own. You can use Anki, whatever it is, but really this is the only few weeks where I'm really going to recommend that you rote memorize information. And then after this, we're going to move on to applying, and we're going to be talking more clinically and more functionally, and you're going to settle into your comfort zone. Bear with me, trust me that we will make it through. Okay? All right. Moving back on, separation anxiety. All you really need to know about this is that kids don't like to be separated from their caregivers, and this is a huge exam, a bit of information for your exam. I don't know why I can't talk today. You will never separate a child from their caregiver when able. We're always going to encourage caregivers to remain at the bedside. Families sometimes don't have a choice, right? Sometimes they have other children at home and they don't have childcare. And so sometimes there are infants that are left at the hospital or toddlers for certain periods of time. And so separation anxiety, we can definitely see it, and it definitely peaks around early toddlerhood, but you can still see that in any age group. Loss of control is another big issue for children. Obviously, same with adults, okay? Nobody likes losing control, and kids can express that in different ways. I won't read through all of this, but just be aware that hospitalization is more challenging for kids because of their limited understanding of why they're there and what is going on. Kids who have chronic disorders, who experience frequent hospitalizations, might have negative experience from the past that they bring forward with them to a current hospitalization. So that can actually heighten their fear and anxiety when you might assume that they're okay with something. You never know. And then obviously, as nursing staff, we need to recognize those challenges and help implement strategies to improve communication, involve kids in their care to whatever extent possible we can, and provide support to help them cope with that stress. The hospitalization of a child also affects the family and the siblings, and it's important to remember that. Families can experience a range of emotional responses, including anxiety and depression, sleep deprivation, any outside burdens, whether they be financial, childcare, work-related, are also part of the context here. And having resources available, having social work available if necessary, is really important, especially with that disruption of their normal routines and potentially their outside resources. Siblings as well can be affected, especially the siblings of children with chronic illnesses. Not something that we work with a lot in the hospital, but important to just know for the world of pediatrics that a sibling can experience jealousy and sadness and loneliness and guilt because that hospitalized child is receiving more attention and gifts and care. Parents need to recognize that as well to help support the siblings, because in the moment it seems like the sick child is the one that needs all the attention, but there are other kids there too that are being affected by the circumstances. As far as nursing responsibilities to minimize stress, we focus on family-centered care and atraumatic care. We try to minimize traumatic experiences. So sometimes in peds that often looks like maybe not drawing labs as often as you might see in the adult world, where we're following up on CBCs maybe for an infection. In peds, we don't usually do that. We'll get a baseline set of labs, and unless we're really concerned about something, we will look to clinical signs for improvement rather than continuing to poke a child that doesn't need to be poked. We want to give clear explanations, as I mentioned before, providing choices for that child and allowing them to touch and hold equipment when it is feasible and appropriate. Teaching about the same thing, okay? Just having the parents stay at the bedside, bringing items from home that can help that child stay comfortable, involving resources in the hospital that can help children to cope. Child life is a huge resource that we have. These are developmental experts that are at the hospital that work to help children cope using developmentally appropriate techniques and strategies. They're more present lately in the ER and the ICU and in surgery, but they do come up to peds for rounding and for any sort of invasive procedures like IV starts and NG tube insertions and things like that. Activities and play are really important. Play doesn't stop just because the kid is in the hospital. And so I always encourage you guys as students, if there's nothing going on, find a patient to play with. It is just as therapeutic and helpful as giving them a medication, and it really helps you learn how to interact with that child and to better understand where they are developmentally. For infants, this looks like just maybe providing music or just talking to them softly or giving them a stuffed animal or a rattle, depending on what's appropriate. That can be beneficial. Holding is really important. Anytime we have babies that are by themselves, I always put students in with those kids so that they can have that contact and that interaction. Toddlers enjoy music as well. Things like stacking blocks, painting, coloring. Reading to toddlers helps support their language development, and that's also very useful. Preschoolers are usually doing similar activities as toddlers, but could benefit from some pretend play like dress up or arts and crafts. School-age children tend to like peer interaction, which can be hard, especially if everyone's in isolation, but they also enjoy arts and crafts or board games, card games, video games. And then adolescents, obviously peer engagement is huge, so a lot of times they'll be on their cell phones, but just talking to them about themselves usually helps open them up, letting them personalize their space maybe with some things from home. And if you can get them off their cell phones, sometimes they like to play games too. Discharge teaching, as always, in adults and peds should begin as soon as possible during hospitalization. This is not really something you're going to be focused on, but it's just important to recognize that we are always teaching. Every time you go to the bedside, it is an opportunity to teach, and including that child if appropriate. Okay? So I want you to think about these questions real quick because I think they're important. So what are the common challenges healthcare providers face when performing diagnostic procedures on children? And if you want to rephrase this, think about what would you be afraid of if you had to go in there and I said, hey, we need to go start an IV in room 8, okay? What would you be concerned about if this was a 3-year-old or an 8-year-old? I want you to think about how you would maybe utilize resources on the unit or just with your knowledge of development to help make that easier for that child. Second, how can healthcare providers effectively communicate with children and their families about the need for diagnostic procedures and what to expect? Again, break this down into age group. How would you describe it to the parents of an infant versus a school-age child who would be maybe included in that explanation? And how would you approach explaining it? What kind of language would you use? And third, what strategies can be employed to reduce fear and anxiety in children undergoing diagnostic procedures? We talked about some of this, right? Utilizing child life, utilizing some pre-teaching and some preparation. Distraction is really great with kids, having them watch a TV show, play a game, maybe talk to somebody in the room. Sometimes we'll have kids blow bubbles, blow on a pinwheel, things like that. We can also use their sucrose solutions for infants, which is like a sugar solution that we can put on their pacifier or on a finger so that they can suck, and that usually helps with pain management in children. So there's lots of options out there. So just be prepared to learn about those things and be aware that they are there. And that leads us into med administration, okay? Dosage by weight is typical in peds. Safe dose ranges are really important. It's something you're going to be practicing in the clinical setting, is knowing how to calculate those dose ranges and recognizing them, knowing your routes of administration, And being aware of how to administer medication in peds, I think, is the most important thing, because an oral medication to an adolescent is going to be different than a toddler and probably different to an infant. And so understanding how to administer those medications and also knowing about these comfort holds that are here on the right could be really useful when you're having to do something that's a little bit more invasive. So as far as you, student nurses in pediatrics, I talked about a lot of this already, but I just want you to reflect a little bit about what you're most nervous about, okay, coming into pediatrics. Some of it I can help you with, some I cannot, but you should start reflecting now about what you're nervous about and what you can maybe do to help alleviate those nerves. Think about how you can apply your previous experience to pediatrics, because there's a lot that you know and you don't want to discount that experience. Start identifying resources that you can use to help you in this semester so that you're not quite so overwhelmed. If that means finding someone in your clinical cohort who absolutely loves kids and is really good, when you know that they're willing to pep talk you through walking into the room the first time, or watching a bunch of videos on YouTube about children, whatever it might be, to help you feel more comfortable. And just keep in mind that everything in this course and in this rotation is a learning opportunity. You're going to be spending 8 weeks in the hospital and 8 weeks in a classroom, which will give you a lot of insight into sort of normal development and normal behavior of a certain age group, whatever grade class you are in, that you can then take to the hospital and apply. Or if you're going to the hospital first, then you can take all of that experience and interaction to the schools, and after having seen kids outside of their comfort zones, you'll then see them somewhere where they are very comfortable. But both rotations are learning opportunities with different benefits, and I'm a strong proponent for like really being self-aware about what you want to gain from this class and from your clinical experience, and getting out there and doing it. I can only help you if you tell me what you need help with. And so reflecting on what you want to learn before we even start is a great first step, so that as we move forward, you can start refining that and honing in on those areas that you really think that you want to know more about. And I am more than happy to help you and support you through that. So bring your questions, bring your interests, be comfortable with talking. Okay, this is not a class where I'm going to talk at you for 2 hours. I don't like that. I don't think it's useful. And so I really depend on you being willing to do the scary thing and raise your hand and ask a question, so that I know how best to teach you as individuals, because every class is different, every student is different, and I want to make sure that I am giving you the information you need in the way that you need it.